Hello, dear friends. My name is Dr. Saf, and this is an interesting topic, and I'm very glad that it was allotted to me during the Criticare 2024 organized by Indian Society of Critical Care Medicine. So thanks to scientific committee, and if we look at this topic closely, the rational use of calcium and phosphorus in ICU, it's about justifying the correction of hypocalcemia and hypophosphatemia in ICU. How common these two entities are in hypocalcemia and hypophosphatemia, and should we really correct it or not? But before that, uh, as you know, physiologically, calcium is an essential ion. 99% of calcium is stored in the bony skeleton along with the phosphate, and only 1% of these two ions reside outside the intracellular fluid, that is extracellular fluid, and basically in the vascular system in the blood. So if we look at the role of calcium ions, we should be mesmerized by the various roles it has. Important as an important second messenger, involved in cell-to-cell signaling and cell-to-cell communication. It also regulates the cardiac myocyte function, and its important role. It has important role in the cardiac conduction because it is responsible for the plateau phase of action potential in the cardiac myocyte. It also triggers the neurotransmitter release, that is acetylcholine, through presynaptic voltage-gated calcium channels in the membrane of the motor nerve terminal. And if it is deficient, for example, if there is autoantibody to voltage-gated calcium channel, you might get a problem like the ICU weakness or the weakness, simply weakness in the syndrome called Lambert-Eaton myasthenia gravis. So this is a particular syndrome where voltage-gated calcium channels are attacked by the autoantibodies, okay, like in myasthenia gravis, and patient develops the weakness, right? So this is where it is important. It also plays an important role in tight regulation of coagulation cascade, which is important in the maintenance of hemostasis, that is clotting. So it has so many crucial action, the calcium. So this is why it has to be maintained in a narrow level using various regulatory mechanisms and hormones. For example, parathyroid hormone, which is secreted by the parathyroid glands in the neck, and calcitriol, that is vitamin D3, which is uh, which is synthesized and activated in kidney and liver, okay, and also the hormone calcitonin, which is again released from the glands in the neck. And I'm not going into detail of how it is regulated, so it is regulated like that. But rather, let's move on to discuss the hypocalcemia in critically ill patients. So it is common, it is very, very common. About 55 to 88% of critically ill patients can have hypocalcemia. I'm not going to talk about whether this is symptomatic, what are the percentage of the patient which develop symptomatic hypocalcemia in ICU. It is just a finding that hypocalcemia, which is defined as the ionized calcium less than zero point 0.8 or zero point 0.9 millimole per liter. That is the definition. So if patient has hypocalcemia, the incidence of it, the incidence of hypocalcemia in ICU is very, very high, 20%. And it usually results, the mechanisms of hypocalcemia in ICU. So it is usually results from impaired parathyroid hormone secretion or action, impaired vitamin D synthesis or action, or calcium chelation in the blood. So a number of studies have reported that hypocalcemia is associated with bad outcomes in different ICU populations, including medical, surgical, trauma patients. However, results from major studies, various large studies, especially recent studies, suggest that it is only severe hypocalcemia that is independently associated with mortality. So severe hypocalcemia is defined as ionized calcium less than 0.8 millimole per liter. So, okay, if hypocalcemia is so common in ICU, and it carries poor prognosis as per studies. Let's correct it and make our patients safe, right? But, uh, but if we look at the evidence, it is not strong enough due to majority of it is retrospective and unclear. And also, it is unclear because few studies showing positive outcomes and few other studies showing negative impact of calcium supplementation. The most extensive study, you know, which is which was done by Zhang et al. In 32,000 mixed ICU patients, which concluded, the study concluded that calcium supplementation may be associated with better 28-day survival. So this is a positive study. Another big recent retrospective study completed in 2022, it was published in 2022, in 5,800 septic patients showed that calcium supplementation reduced the mortality when SOFA score was more than 8, but it worsened the outcome when the patient's SOFA score was less than 4. So you can correct a patient is having really bad SOFA score of more than 8. It may help according to this study. But still, we need to wait for large prospective data or a clinical trial before we start routine supplementation or routine correction of hypocalcemia in ICU. Therefore, it shall be wise to administer calcium when there are overt severe hypocalcemic symptoms like tetany or like seizures or laryngospasm. Okay, so if patient has severe symptomatic hypocalcemia, you can go ahead and correct the calcium level. Or if there is pulseless tachyarrhythmia like SVT or VTAC in a patient with hyperkalemia and ESRD who missed dialysis session, you can give calcium to stabilize the cardiac membrane. So this is another indication. One more indication which is off-label is to use the calcium in beta blocker overdose or toxicity because calcium can increase the inotropy in the heart. It can increase the heart rate. That is why you can give, but this is off-label indication. Okay, so these are the therapeutic indications for calcium replacement. There are some other indications as well where you need to monitor and correct ionized calcium. For example, during CRRT, especially when you are using regional citrate anticoagulation, where citrate can combine with the calcium in the blood and develops, and result in the hypocalcemia. So there is a protocol, institutional protocol, where you can measure, monitor the calcium level pre-circuit, post-circuit, and accordingly you can correct. So there are various protocol, but for the correction, they use usually calcium chloride rather than calcium gluconate. Massive transfusion is also associated with hypocalcemia due to citrate, toxicity caused by the massive transfusion. So recently, lethal triad of trauma has been converted into the lethal diamond of trauma after inclusion of hypocalcemia into the triad. In a retrospective study in 7,500 trauma patients receiving massive transfusion, the prevalence of severe hypocalcemia was 10% after 48 hours of admission to trauma center. So this was published in World Journal of Surgery. And this is just to highlight the importance of this hypocalcemia in the lethal diamond, so that we should correct it, okay, and we should monitor it definitely in a massive transfusion case. Hypocalcemia has also been observed in up to 30% of tumor lysis syndrome in oncological patients, but in TLS, hypocalcemia should never be corrected until it is symptomatic. Otherwise, it will lead to deposition of calcium phosphate in kidney tubules, contributing to acute kidney injury. So beware of calcium correction in a patient with TLS. Okay, so this is important. Now we will move on to phosphorus. So this is second electrolyte, which is important and consists of phospholipid, ester phosphates, and inorganic phosphates. Phosphorus plays a critical role a critical role in many biological processes, including energy metabolism, cellular signaling, nucleic acid metabolism, and membrane integrity, etc. So it has to be maintained in a narrow normal range between 0.8 to 1.6 millimole per liter. Many causes of hypophosphatemia are possible, like transcellular shifts and renal losses are a major one. Severe hypophosphatemia has neuromuscular and cardiac manifestations mainly. Hypophosphatemia is associated with difficulty in weaning also. Okay, the patients who are difficult to wean from mechanical ventilation should suspect the hypophosphatemia. Now, regarding the rational use of intravenous phosphate supplementation in ICU, should we really correct hypophosphatemia in all patients? How common it is? So it's quite common. You can say to 30 to 40% patients can have hypophosphatemia in ICU. In few patients where hypophosphatemia is symptomatic or severe, you can replace, for example, patients at the risk of refeeding syndrome, especially when we start on TPN, or patients with DKA or HHS, or the patients who are on CRRT. These are the patients where hypophosphatemia can be a concern and we should be correcting it. Now, regarding the routine replacement for the, biochemical abnormality, just biochemically deranged hypophosphatemia, there are certain facts we should be aware of. Okay, like the evidence is unclear and consists mainly of retrospective studies again, as we have seen in calcium, regarding the association of hypophosphatemia and mortality. So there were studies which were positive, there were studies which were negative. So combining all the retrospective data, we have meta-analysis published in 2021 in Journal of Intensive Care Medicine. This was a meta-analysis including 12 studies and 7,600 participants, which concluded that hypophosphatemia was not associated with mortality. Only positive associations found in this meta-analysis were increased hospital length of stay, okay, and increased ICU length of stay. These were only positive association, but there was no increase in mortality when there was hypophosphatemia in ICU. Another recent large meta-analysis showed that not hypo, rather hyperphosphatemia was associated with higher mortality and bad outcome and prolonged ICU stay as well. Now, very recently, for the first time, a prospective study was conducted in 300 patients which showed hypophosphatemia is associated with. So this is the only study which I found on internet, on Google, on Google Scholar, or you can say NLM, National Library of Medicine, which was done in a prospective, kind of as a prospective analysis compared to all these previous retrospective studies. The first study which showed better outcome with hypophosphatemia. Okay, so it means that it should not be corrected, right? So lot of problems. Now, therefore, hypophosphatemia should not be corrected routinely unless it is overtly symptomatic in few conditions like refeeding syndrome or DKHHS, ERRT, and difficult weaning from mechanical ventilation. Various IV formulations and protocols are available to treat hypophosphatemia, and one such protocol is shown here. You can see, you can take a snapshot of this. So we have to be careful in patients whom we are supplementing IV phosphate, because it can cause few issues. If patient has hypocalcemia, it can reduce the calcium level further, and patient may develop the symptomatic hypocalcemia. So we have to be very careful and monitor calcium level. If hypotension occurs during infusion of IV phosphate, consider the possibility of hypocalcemia always and try to correct calcium level. So bottom line facts are, which are the conclusion of this lecture, that there is unclear, weak, and mainly retrospective evidence regarding the correction of ICU acquired hypocalcemia to improve clinical outcomes. It seems likely that hypocalcemia is an adaptive response to critical illness and tissue damage instead of cause of cell damage and dysfunction. but this requires confirmation in future studies. Hence, we need prospective studies to assess the risk and benefits of calcium supplementation in ICU hypocalcemic patients. Now, regarding the hypophosphatemia, it is not a strong predictor of mortality. However, it may lead to prolongation of ICU stay. Therefore, routine correction of hypophosphatemia is also not advisable. Both hypocalcemia and hypophosphatemia should be corrected in a specific subset of the ICU patients only. So this was whole crux of my presentation. Thank you for your attention and understanding, and I appreciate it very much. And you can follow my YouTube channel, my Instagram channel page there, and support my channel also, because I always try to give you the important, authentic facts in critical care, information which is useful in your daily practice. Thanks a lot. Bye bye. Take care.